sensitive and private nature. And so what I'm going to do is clear the courtroom, bring the juror in so that I can question her about it. And I will ask if the juror is comfortable discussing it in open court. If she is, then, I'll have everyone come back in the courtroom. But given the nature of the inquiry, this is the only way that I can think of how to proceed. So based on that, I'm going to ask everyone in the courtroom who's not an attorney on the case or a party in the case to please exit the courtroom. Right. Okay. Back in the courtroom. Is the camera ready? It's back on. Okay. All right. And the record should reflect that juror number 535 is still present in the courtroom. If at any point you want me to clear the courtroom, would you please just let me know that?
Yes.
That's not a problem, okay? And I very much appreciate your patience with me. As a follow-up question, you indicated that you have issues with your back, and today is worse than perhaps other days. Is that right?
Yes.
Okay. And does that sometimes make you unstable on your feet?
Yeah.
Yeah. Okay.
Because I have a hardware in my back and I've got a spinal implant.
Okay.
Yeah, it hurts today.
Okay. And you're becoming emotional, and I appreciate that. I just want to make sure that you're okay and that the pain is not so severe that it is distracting.
I've lived with this for a long time.
Okay. All right. And so are you able to proceed then today?
Yes.
Okay. The pain is present, but it's not something that's going to interfere in any way with your ability to concentrate on the proceedings and to pay attention fully to the proceedings. Is that correct?
That's correct.
Okay. All right. In terms of the sheriff that I mentioned a moment ago who had made the particular observation earlier this morning, I just want to make sure that just because he is a deputy with the Arapahoe County Sheriff's Office, and we've had some witnesses testify in this trial from the Arapahoe County Sheriff's Office, that you're not somehow going to hold it against those witnesses in any way.
No, and I can understand because, well, you see when I walk down here, I have to hold onto the wall.
Right.
It is what it is.
Exactly. And there's nothing wrong with that. I had to follow up with you, that's all. You understand?
Yeah.
Okay. We just wanted to make sure that there was nothing else going on and that you're able to proceed. And you're saying there's nothing else going on and you're able to proceed, correct?
Yes.
Okay. So the discussion we've had here today, that's not going to affect your assessment of the credibility of any of the witnesses, including witnesses from the Arapahoe County Sheriff's Department.
No, there's not a problem.
Okay. All right. Is there anything else that I need to know about? Is there anything else that affects your ability to think or to concentrate or to pay attention at all on the proceedings?
No.
Okay.
No.
And you're not under the influence of any medication or substance that affects your ability to concentrate and your ability to pay attention?
No, I don't take any of the serious pain medication unless I'm at home. I don't do that here.
Oh, okay. So while you're here, you're not taking any of the
I've got medication, but it's not a narcotic or anything like that.
Nothing that makes you tired or sleepy?
No.
Okay. And that's true for today as well?
Yes, sir.
Okay. Is there anything else that you want to talk to us about?
No.
Okay. I hope you understand that once the information was provided to me, I had to follow up, and you should not...
I understand.
Okay.
I understand, and I'm sure walking down the hall, it's obvious that, having difficulty, so...
please don't infer from this that
I won't.
I thought that you had done anything wrong or that there was an issue here. I just needed to follow up with you just to make sure that what I believed was true,
I
okay?
understand. I
All
do.
right. All right.
It's
Thank
okay.
you very much. I'm going to have you wait outside for just a moment, okay?
Okay.
All right. Thank you. The record should reflect that juror number 535 has now exited the courtroom. Are there any additional questions that the people would like me to ask or any action that people would like me to take at this time?
None, Your Honor.
Any questions that the defense, any additional questions the defense would like me to ask or any action the defense would like me to take? Okay. All right. I'm comfortable then that she is not she's not having any issues today that are affecting her ability to think, her ability to pay attention, her ability to concentrate. I think she indicated that she has some back issues. We've generally been aware of that, and so we'll just proceed. Let's have her back in, please. The record should reflect that juror number 535 is back in the courtroom. I just wanted to thank you for your patience and then tell you that if at any point you need a break or you're in pain and you need to stand or stretch, just let us know that you need to take
I
a break,
will.
and I would be happy to take a break, all right?
I understand, and
Okay.
I will.
Wonderful. Thank you so much.
Thank you.
All right. The record should reflect that juror number 535 has exited the courtroom again. Are the parties ready for the jury now?
Yes, Your Honor.
Yes, Your Honor.
Okay, let's bring the jury in, please. Thank you. Please be seated, everyone. The record should reflect that the jury is back in the courtroom. Welcome back, members of the jury. I hope you had a good lunch. That was a much longer lunch than I had anticipated, but hopefully you were able to enjoy the little time you had. Would the defense please call its next witness?
Dr. Raquel Gurr.
Good afternoon, doctor. If I can have you raise your right hand so that I can administer an oath. Do you solemnly swear or affirm under penalty of law that the testimony you're about to give will be the truth, the whole truth, and nothing but the truth?
I do.
Please be seated. Could you please tell us your full name and spell your first, middle, and last names?
Raquel, R-A-Q-U-E-L, middle initial E, last name Gur, G-U-R.
All right, Mr. King, you may proceed.
Thank you, Your Honor. Good afternoon, Doctor.
Good afternoon.
Doctor, I just want to ask you a few questions here about your vocation, and then we can go into some more detailed areas. You are a doctor of what?
I'm a doctor of medicine with specialty in psychiatry and neurology.
Okay. And what was
I
the
also
second?
have a PhD in psychology.
Okay. And you said that you were a medical doctor, and if you could, pull that microphone up close to you there, and please try to talk as slowly as you can. You have a little bit of an accent here, so we want to make sure that the jury can understand what you said.
I'll do my best.
Okay. You said you were a medical doctor, and what was the rest of that?
That with specialty, with residency in psychiatry and neurology, and a PhD in psychology.
Okay. Can you tell us a little bit about the education that you've gone through in order to achieve that? Where did you go to, where did you get your undergraduate degree first?
So I started at the Hebrew University in Jerusalem, Israel, where I completed 2 years. In Israel, the undergraduate education is 3 years.
Okay.
I completed 2 years and transferred to Michigan State University, where my husband was pursuing a graduate school in psychology. So we transferred as a professional couple, and I obtained my degree, my Bachelor of Science degree at Michigan State University.
Okay. And then did you follow that up with a PhD, or did you go to medical school after that?
I stayed at Michigan State University, completed a master's in psychology, continued to the PhD in psychology, with clinical psychology with a minor in developmental, and then went to Stanford University, did a postdoctoral and clinical fellowship there in psychology, then came to the University of Pennsylvania and pursued a medical school at the University of Pennsylvania, and then residency in neurology and psychiatry.
Okay. What year did you graduate from the medical school at the University of Pennsylvania?
1980.
Okay. And then did you first do your residency in neurology, or did you first do a residency in psychiatry?
I started with a residency in neurology, but pursued activities in psychiatry. They gave me permission to do a combined effort because of my interest and demonstrated abilities, I will say, and then followed with psychiatry. So it was a total of 6 years.
Okay. And are you licensed as a medical doctor in the areas of psychiatry and neurology?
I'm licensed at the state of Pennsylvania and also for psychology.
How long have you been a practicing psychiatrist and neurologist? How many years?
Since 1984, first as neurology, and then 1986 since in psychiatry. So,
Your Honor, I would move the admission of Dr. Gurr as an expert pursuant to Rule 702 in People v. Schreck in the areas of psychiatry and neurology.
Is there any objection?
What, Your Honor?
Okay.
Good afternoon.
good afternoon.
Doctor, I want to make sure that I know the limits of what your expertise are and if you've ever testified as an expert before and how that's been, okay?
Judge, objection. May we approach?
Sure. All right, the objection is overruled, but Mr. Proctor, you must proceed as we discussed at the bench.
Thank you, Your Honor. Good afternoon.
Good afternoon.
Again, sorry.
Again.
Just in exploring the limits of your expertise, I want to make sure that I understand. And do you remember the areas that you were just offered as an expert in?
Yes.
Was it psychiatry, psychology, and neurology?
I was asked about my training, which is in psychiatry, neurology, and psychology. My expertise in practice, primary appointment is psychiatry at the University of Pennsylvania.
Thank you. And I want to make sure, too, I've looked at your curriculum vitae, which is a big resume. You'd agree with that, right?
I hope so.
Yeah, it's big. That there's nothing in there about you being forensically trained or an expert in forensic psychiatry, neurology, or psychology. You'd agree with that?
Objection, beyond the scope, irrelevant.
Overruled.
Go ahead, ma'am.
I am not forensically trained and never wish to be.
And ma'am, you have testified that I can tell as an expert witness only 2 times in criminal matters in your career. Is that fair?
Objection, beyond the scope, irrelevant.
Overruled.
Go ahead, doctor.
So I have testified for competency to be executed in the case of James Billiot in 2008 at the state of Mississippi, and he has not been executed. And I've been retained.
And ma'am, I'm not asking about retained. I'm talking about the times a court has said you are an expert in certain areas.
Okay. And in the case of Dominic Filiposian in 2000, a federal case where the defendant wounded a postal worker.
I understand. Thank you. Those are the only 2 cases in which a court has qualified you as an expert. You'd agree with that?
Correct.
One of them was, actually 2009, was Billiot, and that was about 6 years ago. You'd agree?
Correct.
And that had, that was not qualifying you as an expert to opine on sanity, but rather, as you offered to us, fitness for execution, correct?
Objection, relevance, beyond the scope.
Overruled.
Go ahead, doctor.
I did evaluate him for sanity as well. It was for competent for execution, but also review of previous court record that related to sanity.
And in that case, you weren't qualified as an expert in neurology or psychology. Do you recall that?
Psychiatry.
Objection, relevance, beyond the scope.
Overruled.
Psychiatry.
Just psychiatry. And then in the case where you actually were qualified by the court as an expert and you were allowed to render an opinion on sanity, that was 15 years ago in the Filiposian case. Is that correct?
Correct.
And in that case, you were not qualified as an expert by that federal court in either psychology or, in psychology.
In psychiatry, I was.
It was in psychiatry.
Mm-hmm.
And to be clear, do you know the difference between a federal court and a state court, doctor?
Yes, I
Okay,
do.
and we're in a state court. You'd agree with that?
Yeah, oh, I know.
And no state court in the country has qualified you as an expert to weigh in on the issues of sanity. You'd agree with that?
Correct.
And you don't have any special training or expertise in Colorado law. You'd agree with that?
Correct.
Objection, beyond the scope, irrelevant.
Overruled.
I'm sorry, doctor, what was your answer?
Correct.
This would be, in the course of your long career, only the second time that a court has allowed you to offer an opinion on the issue of sanity, correct?
Correct.
This would also be the very first time that you would have been qualified as an expert in psychology. Is that fair?
Objection, I haven't asked that this expert be qualified in the area of psychology.
Sustained.
Oh, and
He moved to qualify her in psychiatry and neurology.
thank you. And thank you for correcting me, Your Honor, and Mr. King, I apologize. Would this be the first time you would have been qualified as an expert in neurology by a court?
Yeah, but I'm not asking to be, I'm opining on the psychiatric diagnosis and insanity, which is psychiatric.
But so you're not rendering any opinions on neurology, is that fair?
Within the domain of neuropsychiatry, which is my expertise, because I was also trained in neurology, I will say that my background and understanding and qualification on brain function are beyond most psychiatrists.
Okay.
So I feel comfortable talking about brain function, MRI, because I've been trained in doing that. But my primary focus in the evaluation was on the psychiatric status.
And clinically is what we're talking
Clinically, a clinical neuropsychiatric evaluation, that's what I am.
about. Okay, can I have a moment, Your Honor?
Yes. I'm sorry.
I forgot to ask you. You don't possess any board certification, and you look like you knew what I was going to say.
Correct.
What was I going to say?
You do not possess any board certification in psychiatry?
Oh, I wasn't going to ask that, but do you?
No,
Oh, you're not a board-certified psychiatrist?
correct.
Are you a board-certified neuropsychiatrist?
No,
And you're not a board-certified forensic fill-in-the-blank anything?
correct.
May I have a moment, Your Honor?
Yes.
Be allowed to attend the panel at this rate.
Yes. All right, without objection and pursuant to Rule 702 of the Colorado Rules of Evidence and the decision in People versus Shrek, which is published at 22 Pacific 3rd, 68, Colorado 2001, the court will qualify Dr. Gurr as an expert witness in the field of clinical psychiatry and in the field of clinical neurology. That means, members of the jury, that Dr. Gurr may not render expert opinions in those fields. I want to give you the instruction that I have been giving you throughout this trial when an expert testifies, and that is that you're not bound by the testimony of a witness who testifies as an expert. The credibility of an expert's testimony is to be considered as that of any other witness. You may believe all of an expert witness's testimony, part of it, or none of it. The weight that you give the testimony is entirely your decision. All right, Mr. King, you may proceed with your direct examination of Dr. Gurr.
Thank you.
Doctor, can we talk, I want to talk a little bit more about the path that you followed in preparing yourself for the work that you now do, and then I want to talk a little bit about the work that you now do and what the aspects of that are, if I may. Why did you choose, if there was a specific reason, to get a PhD in psychology first and then do medical school after that?
I pursued a PhD in psychology, clinical psychology, with interest based on undergraduate studies in severe mental illness. And I was interested in research. There was limited amount of research that was done at the time that was high standards and similar to other fields in medicine. And that's why I pursued a PhD before. And as I said, when you asked me about my background, is that I'm married, I have children, and I've always attempted to integrate professional life with my husband and my children. So after the PhD, I did a fellowship, began at the University of Pennsylvania in the Department of Psychiatry to get more experience with individuals with schizophrenia on an inpatient unit. And at that time, I was taking, which is permitted, at the University of Pennsylvania, when you do a fellowship to advance your education. And I began to take some coursework that was permitted and encouraged. So the coursework was in medical school and with medical students. And it was basic anatomy, and it was an opportunity for me to grow and learn more, and some graduate courses in the medical school. And with that, and doing well on it, I almost completed 1 year of medical school over a period of time. And encouragement from faculty in the Department of Psychiatry and Medicine, they've advised me to meet with the dean and say that you have talent, you should pursue medical school. So I met with the dean and went and did all pre-med that I did not complete before, evening courses and 7 a.m. courses, physics, chemistry, so that I can take the entry exams to medical school. And I applied and I was accepted to the University of Pennsylvania Medical School. And the medical school I completed in 3 years because I already had a background. And then I took during medical school courses both in neurology and psychiatry, and realized how limited the knowledge is in psychiatry about the brain, which is really the organ of the mind. So I spoke to the people in neurology and psychiatry, and with their approval did a combined program that will enable me to learn about neurology, seizure disorder, neuropathology, brain cutting, how does the brain work when people have brain damage, and pursued psychiatry on the inpatient, fulfilling all the requirement. So what motivated me to take this lengthy road was to advance the understanding of schizophrenia, a serious mental disorder.
Okay. And before, I think you said that you were, and I don't want to put words in your mouth, but surprised by the lack of real scientific research in the area of the brain and how it affects psychiatric disorders?
Correct. It was really very limited. The number of journals was very limited. The quality of what was published, generating knowledge, was a handful of people in every study. Many of the results were not replicating. New methods were not being applied as if we were in the 19th century. And it was a marked contrast to what was happening in other fields of medicine, in cancer research, in heart research. And I could see the patients and the families coming in and out, and very limited progress. And what I could teach the residents when I became faculty, or as a resident, the questions was not answered. There was just much more that was available. And neuroscience, the study of the brain, was advancing so rapidly, and we were left behind. So it was the effort to really build the knowledge, and this can be done only research and clinical research primarily.
Okay.
So,
prior to, was this about the mid-1970s that you did this fellowship and then went to medical school?
well, I started medical in 1977. When I did the fellowship, was just the year before.
Okay.
Yes, the 70s.
Previous to this in time, was psychiatry kind of less of a scientific endeavor and more of like a philosophical endeavor, kind of, or?
Well, I'm not sure I'd have put in these words, but psychiatry was not respected among other medical disciplines. In fact, I recall that the chair of medicine, after I did the internship, called me in and tried to persuade me, don't go to psychiatry. You'll just be wasting your time. One person will say this and one person will say that. Knowledge was generated, but if you say philosophical, it was not grounded in the brain, as if the brain does not relate to behavior. The answer is yes.
Okay.
It was not.
Thank you. And so before we had the research to understand how the brain works and to ground the behavior in actual brain changes and brain activities, were there concepts, psychoanalytical concepts that were used, like the id and the ego and the superego and other kinds of psychodynamic concepts to try to understand how the mind works?
Absolutely, because the mind, it's a puzzle. It's something that is many times hard to understand, and that concepts were used and applied in an effort to understand human behavior that is complex. Okay. And that's the best we could do at that time. Okay.
And since then, has the research shown that there actually is like an id or a superego or an ego, or I mean, are those actual brain structures?
No. It's a concept in order to try to understand behavior. No. In other words, there's no part of the brain that I can point at and say, this is what the id is, or this is what the superego is. No. And interesting that when you ask is that when I was an undergraduate, this was a big motivation to pursue schizophrenia, is that I was taking a course in abnormal psychology. And part of the course was to go for one semester to a state hospital in Jerusalem, and each one of us was assigned a patient. We didn't choose, but introduced to somebody to be a friend, visit. And the young person I met had schizophrenia. And at that time, in the classroom, we were learning much more about the schizophrenogenic mother, namely a mother with a refrigerator and produces children with schizophrenia. It's all at the mom. Many times we get this blame. But I got to meet the family. And the mother could have been my mother. And it sort of opened my eyes a little bit to say, what else made me going on with these people? It's not the mother. And I began to read more of the literature and decided to pursue schizophrenia.
Okay. Tell me a little bit about, you did your residency in neurology first, I think, 1981 to 84. What did that involve?
It involved 3 years. The first year, because it was an integrated program for me, the first year commonly in neurology is medicine, full year of medicine, emergency room, intensive care, with the medical residents. Because I knew that I was doing neurology out of interest in psychiatry, in serious mental illness, they agreed to have a plan for me that I spent 6 months in medicine with the medical people and 6 months on inpatient psychiatry. So I did additional inpatient psychiatry, working primarily with psychotic people. This was the first year. The others involved inpatient neurology, outpatient neurology, that some of it was general clinic, some of it was epilepsy. There was, in addition to what was mandated, there was always elective, and my electives related more to behavioral aspects of brain damage. So I saw patients with multiple sclerosis, MS, with psychotic features, behavioral problems. I saw individuals with dementia, Alzheimer's disease, and psychotic features. So I increased my expertise in brain disorders where behavioral manifestations are a challenge, and many times neurologists don't know how to deal with it and require psychiatric expertise. So I will join the psychiatry consults to work with them on patients with serious brain disorders, neurological disorders.
Okay. And when you were doing this residency, was that at a specific hospital? Was that at the University of Pennsylvania?
It was at the hospital of the University of Pennsylvania in Philadelphia, that is part of the University of Pennsylvania, and at Graduate Hospital, that at that time is one of the largest epilepsy programs in the country, specifically specializing in temporal lobe epilepsy and intractable seizures. And I published on it. It's reflected in my CV.
Okay.
So I was doing research on individual cases where you can learn from one case a lot.
And is that when you began your research, really, at that point when you were in that residency?
I did it a little bit before. I began before,
Okay.
whenever I could.
And has that always been your interest in academia and in doing and in being a scientist in this area, essentially?
Correct. And that was just partly my response, that I never considered forensic, because I knew that I'd like to pursue brain behavior research.
Okay. And then from 1984 to 86, was that your residency in psychiatry at the University of Pennsylvania?
Of 2 years complete psychiatry. As I said, I did 6 months of inpatient psychiatry as part of the first year of neurology, worked with consultation liaison whenever there was an opportunity to integrate the two. But this was only psychiatry without neurology at all.
In the previous, you said 1 year that involved psychiatry. Were you seeing seriously ill psychotic patients during that period of time?
Only seriously ill psychotic patients.
And what did your residency in psychiatry involve from 84 to 86?
It involved inpatient psychiatry, consultation liaison, and outpatient psychiatry that was broader. It wasn't schizophrenia, but it was mood disorder, anxiety disorder, any cases that individuals who came in seeking for help, postpartum depression, even to broaden the expertise.
Okay. During this period of time when you were doing your fellowship there, before you began and then doing your medical school, and from 1975 to 1987, were you also teaching?
Yes, I was teaching. I was providing teaching resident in psychiatry graduate students, the way things are organized, there are specific lectures for some coursework in graduate school, in neuroscience, there are specific lectures, and I will provide lectures that relate to schizophrenia. We try to integrate it within other programs so that others will be exposed to it, and even if they do research, will aspire to work with the clinical team to do research. Yes, I was also teaching undergraduates. I gave a seminar that related to schizophrenia, and I was teaching on sex differences. One of our areas of my area of interest is sex differences. How does the brain of males and females differ? Because mental illness can be differently expressed in males and females. So I was teaching on that.
Are you saying that the brains of males and females work differently?
Of course, didn't you know that?
I am shocked to hear that. Was your position during that period of time the position of assistant professor?
Yes. My primary appointment has always been, and it started in the Department of Psychiatry, where it has been maintained.
Okay. Mm-hmm. What did you do when you finished your residency in psychiatry in 1986?
I became the director of the neuropsychiatry section. The way a department is organized, most departments in the country, and the Department of Psychiatry at Penn is large, with 100 faculty, few professors relatively, and few female professors.
Was it that large back then?
No, it was not that large. It was smaller. There were maybe 60 people, but it was already divided into sections. There was no neuropsychiatry section at the time. It was primarily depression, substance use. There were at the Robert Sadoff, there was a program in forensic. And we had a new chair, and a new chair at the time when I finished the training, they tried to recruit me to other places, and I stayed at Penn with the understanding that I will have an opportunity, because of my background and interest, to develop a program, a section in neuropsychiatry. Someplace it's called section, division, and I currently direct this section or division in the department.
Okay. How long have you held that position as director of the neuropsychiatry division at the University of Pennsylvania?
From 1984 till now, so time flies.
Okay. And what do you do there? This just so that you know, this jury's heard some information about the neurology program that Mr. Holmes was part of at the University of Colorado, and that there are research scientists, that there's a primary research scientist in each lab, and then how is your program similar to that, or how does it work?
Well, so our program, as I said, is a part of psychiatry that is a clinical department that is also basic scientists, recognizing PhDs in neuroscience, recognizing the importance of translating basic to clinical knowledge. So in our program that is fairly large, currently in our program, I direct close to 60 people. So there are about 10 faculty members, in addition to myself, I didn't think you'll ask me of it, so I have to count and be accurate. 1, 2, 3, 4. There are 4 MDs in addition to myself. One of them is an MD PhD in neuroscience. And the PhDs, 3 of them are clinically licensed, and one of them is just a research neuroscience.
Okay. What are the areas of research that you've pursued over the years, generally speaking?
Me?
Schizophrenia.
So if you look, so the major area of research has been schizophrenia, that has been federally funded by the National Institute of Health, section National Institute of Mental Health, and most of my research work and publications in referee journals or chapters in the American textbook of psychiatry are on schizophrenia. That's my major area. Notably, when studying schizophrenia, it is important to compare them to healthy people, what we call typically developing, because otherwise, how do you know that it's abnormal? So a big part of the effort in the program is to study healthy people across the lifespan, so they can be compared to people with schizophrenia. In the past few years, with the ARA funding, these were funding to stimulate the economy that close, about 2010, that were provided. Investigators could compete for them. I've expanded the effort of the program to look at neurodevelopmental disorders. So to look at other disorders, to compare young people at risk for schizophrenia or very early in the course of schizophrenia to other disorders. And this has culminated, I don't think it's in my CV because it's just as of July 1, in the creation of a new institute at Penn that I direct that is called Lifespan Brain Disorder and its institute, and it's across Children's Hospital of Philadelphia that is on campus and the University of Pennsylvania to look at serious mental disorders from childhood to young adulthood. So that's recent, but all of it is consistent.
Okay. And is that, you talked about investigators, primary investigators, is that the person who's in charge of that lab?
No, so when applying for a grant, there can be a PI, principal investigator, and at times can be a co-PI. Two people can be. These are the people who write the grant, defend it when questions come up, often do, and are responsible for carrying out the research as stipulated in a written application, standard. All applications are standard, how many words you're allowed per section, even what print you can use, and reporting to the government annually and being in charge of it, hiring people, supervising them for ethical conduct of research, integrity of data, maintaining confidentiality, data analysis, etc. So it's an elaborate process. And with about 60 people in the program, it's a lot of work.
And so do you have ongoing, all the time essentially, ongoing research and grants pending? Do you have grants currently now pending with ongoing research going on?
Absolutely. I'm funded to capacity. In other words, you cannot be funded more as far as percent effort. So yeah.
And is there a lot of competition for those grants in terms of demonstrating the importance of your research and the quality of your research?
About 15% of grants are currently funded. And I would say it's not because the others are less good. Some are, but they're limited funding. They're just limited funding for medical research across the board. So in recent years. So some of the progress is slower because there's limited funding for research. But it's a tough competition, yes. Almost as tough as being in the courtroom.
Have you continued to teach over the years as
yes.
well?
With the increase in research effort and dedication to it, I've carved out my teaching responsibilities. So more common in an academic setting, junior people, when they are promoted, I've been promoted, I can't be promoted anymore, I have an endowed chair. So in all of the Department of Psychiatry, there might be 3 endowed chairs. And this is a donor is giving money, and the university selects somebody of worthy to give them the money. So I have an endowed chair. And other people, junior people, who need to be promoted, they're promoted on the basis of research, clinical care of patients, and teaching. So they are primarily in charge of teaching, but I do teach the residents on the frontiers of schizophrenia, where we are and where we are going. So I give them a 2 to 3 hour seminar. I teach I give lectures in the Department of Genetics. A lot of the research that I do, federal grant, is in collaboration with geneticists on the genetics of schizophrenia. So I teach on that. And I teach neuroscience students to make sure that they think about schizophrenia. So the course directors encourage students, and our students, PhD students, and rotate in our laboratory and pursue research on schizophrenia. And that's something that I'm proud of, that they think that schizophrenia is important, is a brain disorder. They've accepted it. It wasn't like that several years ago. I had to fight for it.
So you said you were an assistant professor till 1987. Were you then promoted, I guess promoted is the word,
Yeah.
to associate professor?
Associate professor with tenure. When promotion occurs, there are several tracks in academic center. Tenure is the highest level. It reflects a commitment of the university to a faculty member. I mean, we are ready for you to stay with us. So as an assistant professor, you're not tenured. You have to demonstrate your abilities, and you are peer-reviewed. There's a committee that reviews your progress every 3 years. You subject your CV, your papers, letters of recommendation from outside peers that are not your colleagues, you've never published with them, and are coming from top universities in the country and abroad. And then a committee sits and evaluates it in the department, the School of Medicine, and the Provost Staff Conference. And that's when you're promoted, because it's sort of like, you know, a long term. It's like the way I take marriage.
They're stuck with you then at that point, right?
They're stuck with me, yeah.
And then in 1989, were you promoted from associate professor to full professor?
Yeah, after 2 years, yes. Mm-hmm.
And what's 2002, the Carl and Linda Rickles Professor of Psychiatry? What does that mean?
So I alluded to it before. It's an endowed chair in academic setting when across departments, when a faculty member's contribution to academia, to science, teaching, and clinical care in the medical school is considered to be of the highest caliber, the university will raise money from, it can be grateful patients, it can be colleagues who want to donate money. There's a special Office of Development that does that, and they raised money. I didn't ask for it. They raised money to give me an endowed chair.
Have you also been had a hospital appointment and continue to work in a clinical setting all throughout your career?
Yes, there is at the hospital, like in any other hospital, there's a committee that evaluates the credentials of each faculty member to practice medicine, and this has to be renewed and evaluated so that what I write, report that I write, the person, I do it for faculty member in my program, but the chair of the department does it for program directors. So there's continuous evaluation and of the clinical privileges, and at times, you know, you have to fill out specific forms that relate to substance use and, you know, any breaking of the law, things like that. So
have you continued to see patients clinically since 1974 then?
Correct.
And in what kind of patients?
So I see patients with schizophrenia, and some of the people that I followed for 20 years. So people who started really young, almost like my kids, and I followed them now for a very long period of time and seen them go through the turmoils. So I've known them and the disorder and their families. So I've done that. In addition to that, the way our program works, we have a clinical care program that provides care to people from the community. And we do have, and it's staffed by psychiatrists, psychologists, social workers. It's a small program, and it focuses on early presentation of psychosis. That's the focus of the program currently. Years back, we saw every person with schizophrenia who will come in. Now, with the department developing an outpatient program for schizophrenia that is staffed by psychiatrists from my program, we could begin to develop a specialty of how to identify early people, early in the course of psychosis. So for this, we have weekly conferences, so that while some of the patients, when a colleague, a member of the faculty in my program would like me to see, I see them in order to provide independent evaluation. If parents want to talk to me, I meet with them with support groups for parents on a regular basis, a group to discuss with siblings, so I'm involved in that. In addition to that, people who come to participate in our research, because we do research on people at risk for early in the course or more advanced cases of schizophrenia. Every person who comes undergoes a standard clinical research evaluation and is also seen by psychiatrists briefly, so that we can put the data that is obtained in research with the clinical. The ultimate goal is really to advance the clinical understanding. And also, so this, I participate in that. We have an on-call system, so if somebody comes in, one of us is available to see them, to answer questions, to obtain informed consent. That is a very important part, especially with vulnerable people. So I participate in that, and we have a weekly case conference where every individual is presented with a written report, and we discuss it and agree on the differential diagnosis and how will they enter into the database. So I participate in that too. So I will say that while the number of people who I provide direct care is more limited, I see multiple people a week.
Okay. And you're talking about now as
I
opposed
told
to
them
earlier on in your
before
career.
I saw many more direct, correct.
You said before that well, first of all, why the focus on early development of schizophrenia? Is that an area of research that's important?
So all of medicine has shifted to early identification and prevention. All of medicine. So in heart disease, cardiac illness, we do not wait for somebody to have a heart attack. We do not. By that time, there's a lot of damage to the heart. And sometimes it's irreversible, even if it doesn't result in death. So what we try to do when somebody comes in, and I give the heart as an illustration, because this is standard of care. And in psychiatry, it's relatively new. So there, in cardiac or heart disease, we take a family history, because the likelihood that somebody might have a heart condition, this runs in family. So if you come to a good doctor, a good cardiologist, they will ask you, is there anybody else in your family who has high blood pressure, for example, or has a heart attack? So we try to identify risk factors in order to change the trajectory. If somebody might develop, might go up, increase the risk, we try to change it a little bit to reduce the risk. So this might be by controlling blood pressure, controlling cholesterol, increasing exercise, weight loss. It's individualized. So this has been part in medicine. It's done for cardiac disease, it's done for diabetes, it's done for cancer. In psychiatry, for schizophrenia, we now realize that when we get them into the inpatient unit, for example, in an acute episode, the train is off the tracks. What we try to do now is to identify through research, because that's the only way to make progress, to identify people early in the course of illness to try to prevent the train, prevent or delay the train getting off the tracks. So that's most of the effort that we do right now.
Okay.
And this is a trend in so it's in psychiatry, maybe to be more focused because maybe I shifted too much, is that a lot of the research in schizophrenia, the number one priority for the National Institute of Mental Health for funding now is early identification of people who show signs bound to psychosis. So most of the research money is invested, a big part is invested in that, and it's global. So it's trying to reach across the Atlantic to have large numbers so we can learn fast.
Okay. You said that your research is clinical research. Can you explain what that means, clinical, the word clinical in terms of research?
So clinical research is done with humans. It's done with people that have signs or symptoms that are associated with a diagnosis. And so that's clinical research. So we do not, my research is not with mice, although I collaborate with people who do that. But it's on human beings with a clinical condition. That's clinical research. And what is done can be very broad. We look at the symptoms that people present with, the effects of medication, the cause of illness. These are clinically relevant and informative questions. But we'll also look at brain function. How does the brain function relate to the symptoms, to the cognitive abilities, into the functioning? How do they do on a day-to-day basis? Being able to function as adolescents, as young adults, move forward.
Have you received a number of, from 1969 through 2014, have you received a number of awards and honorships and in various honorary societies relating to psychiatry?
Yes.
I don't need you to go through them all.
Yes.
Is it like more than a page in your CV?
Yes, I've received multiple awards, some of them from local psychiatric society, because I devote time to meeting with families and, sharing with them the knowledge that we have, and national hospital level and national level.
And are you the president currently of the American College of Neuropsychopharmacology?
Yes, I'm currently the president of this college, to which membership is restricted and you need to be elected by your peers.
Now, what other professional or scientific societies are you part of, if you can recall off the top of your head?
I'm part, and I was ex-president of the Society for Biological Psychiatry.
And what are you looking at, just so that we know? If you want to refresh your recollection...
No, it doesn't.
No,
okay. And
doctor?
yes.
Can you listen to me for one sec?
Yes.
If you need to look at something up there, that's fine. You just need to tell us what it is that you're looking at. So what were you just looking at?
So I was looking at my CV. That's
Okay,
what I
thank
was
you.
looking. Okay.
Thank you very much.
I'm sorry.
And does that refresh your recollection?
Yes.
Okay.
So,
Go ahead.
okay. So I did mention the societies that I've been a member of, and also there are a couple of societies that are there that I'm considering renewing because I might join other societies membership in. But they relate to the Society for Neuroscience, for example.
So that has your membership in that lapsed then?
Yes, it lapsed.
Okay. Was that because you didn't pay your dues or something, or you said you were considering a different organization instead?
Yeah, there's a limit to how many meetings. Once you're committed to a society, I become active in the society, in selecting new members, organizing meetings, and there's a limited number of how much one can do. So I was thinking of letting it go and now joining developmental societies.
Okay.
Because I look more at adolescents, and there are societies for that.
Because the nature of your research has shifted somewhat.
It's shifted, going younger.
Have you, since 1991 through 2013, or held various, or through 2008, held various editorial positions on different publications relating to neurology and psychiatry.
Psychiatry. You know, my prime is psychiatry. My primary appointment and professional identity is in psychiatry.
Okay.
So it's major psychiatric journals that I've been on the editorial board or a publication committee for some of them, and a reviewer, yes. American Journal of Psychiatry, Neuropsychopharmacology, Schizophrenia Bulletin, I mean, all of the major journals in psychiatry.
And have you published articles and books and other publications?
Yes, I have about 400 papers, I believe,
Okay.
and the majority of them are on schizophrenia.
And are the majority of them peer-reviewed publications?
All of them are peer-reviewed. So my CV is arranged according to the standards of the University of Pennsylvania. There are rules. And first come peer-reviewed. What it means is when a piece of research is written up according, and a journal is selected, it is sent to the journal according to the journal's regulation, and it is sent out for review, at least to 2, many times up to 4 or 5 reviewers, expert in the field, that provide written criticism of the study and ask. Sometimes they reject, although it rarely happens to me, and ask for explain more, do another statistical analysis, emphasize this, add a few more references to make it a stronger case, and then before it is published.
Now, are those some 500 publications all listed in your CV?
Yes, they are. It might be that the most recent are not. The CV is dated, is in December, I believe, 2014, and I think, December 2014. So I believe that we are now in July. I'll say there are probably another 20 papers.
I believe we're in July too.
Yes, so there are another 20 papers, probably.
And also listed, is there some of your current research grants, the amounts of the grants, what the studies are studying?
Correct, correct. And there are new grants that have started, and I've not updated it since December, last December. So there are new grants too.
Okay. Judge, if I may approach the witness with what I've marked as DTR 96, please.
Yes.
And I'll show that to counsel. I provided him a copy previously. Ma'am, I'm handing you what I've marked for identification as D-TR-96.
There's my CV, yes.
Do you
Curriculum
recognize
vitae.
that document?
Yes, I do.
And what is that?
This is my curriculum vitae as of December 2014, just before Christmas.
Judge, I'd move the admission of DTR 96.
Mr. Breckler? Yes. All right, that exhibit is admitted, D-TR-96. Mr. King, this may be a good time to take our afternoon break.
Okay.
All right, let's go ahead and do that. Folks, let's go ahead and take 20 minutes. Please make sure you comply with all my admonishments during the break, and I'll see you back here after the break, all right? Thank you. The record should reflect that the jury has exited the courtroom. Everyone may be seated. Is there anything we need to talk about at this time?
The people, Your Honor.
No, Your Honor.
All right, I'll see you after the break. Thank you.